Hello, everybody, and good afternoon, and welcome to another one of our MAG Meet the Specialist sessions. These are a great little way to meet our people that work with us to see what they're really like and to put a face to the name of the doctors on the reports that you get. Today, we're joined by psychiatrist Dr. Ashwani Garg, who's been with MAG for just under a year, and he's fast become a favourite with our clients. He's also just a lovely guy to deal with. So without further ado, Dr. Garg, over to you to just give a little bit of an intro about yourself, your areas of interest and expertise for our clients. Thank you.
Thank you, Michelle, for giving me an opportunity. I mean, this is really a good way to connect, and I understand most of people who refer patients to specialists, they have a lot of anxiety, and there is a lot difference between specialists. So I started doing medical legal work in 2014, and I'm really surprised by the difference of opinion we have among ourselves, and how difficult it would have been for claim managers or lawyers to see the poles apart opinions. So I'm just going to share some of the insights which I've gained over the years. I'll just give you a brief introduction about my qualifications. So I trained in my basic medical degree in India, and I did specialization in psychiatry in India, and then migrated to Australia in 2002, came to Melbourne first as an area of need specialist, started working as a psychiatrist, and retained myself in psychiatry. So I had to do local fellowship, which was the blessing because I have to study again. And this time I really enjoyed doing training because I can understand this time better. So it was really good learning experience. And I worked in public sector for about 10 years and then switched into private and slowly into medical legal. So, and I've done more than 1,000 IMEs, which has taught me medical legal psychiatry. So I don't think there is any training program or book from where you can learn. You basically learn by listening to claimant stories and understanding, and then you realize, okay, this is how things affect people, or this is how PTSD look like, or this is how this disorder manifests in real life. So so it's all about getting that experience and being there, which helps you to build your skills. So I just want to share 4 things which I observed in this medical legal field, which causes challenges for people who are referring claimants for IMEs. So one of the things you often see is a difference in opinion, and it could be sort of quite poles apart, the opinions. And the reason why this happens is there are few different things. The one thing which is very common is bias. So I'm really surprised to see how biased we can be. And this is not someone's fault. This is the way the system is set up. So if you look at the example of the court, there are 2 lawyers who have to take different roles and argue about the case. And that's how the courts are set up. So everybody's trying to prove themselves right. So this medical legal industry, we are divided into defendant and plaintiff psychiatrists. We are supposed to be independent, and we try to be independent, but there's still a lot of unconscious or unintentional bias which happens because we are human beings. You do get attachment to claimant, and you sort of when you listen to story. So you really need to work hard to be aware of your biases, and and try to be independent. So one of the way which I do is I always re-examine my opinion. If somebody has a different opinion than me, then I always go back to claimant, re-examine the patient and try to understand why did I read it wrong or what happened. The second reason for different opinion is the timing. So psychiatric conditions are very um, fluctuating conditions. So when you have IME, something might have happened a week before, a month before, which has completely changed the presentation, and you see sort of patient in crisis, and you give a big impairment rating. But after you've seen patient, someone else sees after a month when crisis has settled, and they might see a very different picture. So you got to sort of understand the psychiatric conditions can get affected by local factors or something happens immediately, and you got to sort of try to assess a longitudinal picture that how patient have been over last 1 year or 6 months most of the time rather than what the person is feeling now. So I'm sure like if you are a claim manager, you can see that what has happened at this time of the IME and why this person is saying this. So you can make sense of that. There is also sort of a lot of lack of awareness of trauma symptoms. So the depression is very common, and but trauma can manifest in different ways, and it requires a lot of listening and understanding when people get affected by trauma. And sometimes that doesn't happen. So the time is the key. So I spend like about 2.5 2 hours with my patient, listening them, understanding them, and that's sort of key to understand. So the other thing is malingering, or we call it more exaggeration of symptoms. So malingering is very uncommon because we have very complex medico-legal system, and a malingerer will find it very difficult to deal with all these things. So most of people we have are genuine claimant, but people do exaggerate their symptoms. So they may report the symptom which they had in the beginning of the injury, and they don't have them now, but at the time of IME, they may say, though, we have these symptoms still. So that is very common. And the way to deal with it is, I mean, our psychiatric impairment rating scales are sort of designed to rule that out. So our impairment rating scales do not consider the symptoms. We consider the functioning. And so people can exaggerate if they want, but it will not affect the impairment rating because it is more based on their functioning. And functioning too has to be a longitudinal functioning. So if you sort of ask them open-ended question, can you walk me through your day? It is very difficult for people to exaggerate that because they have to tell about their daily life and what they do. And the other way to deal is just spending time. Like if you're seeing someone for 1.5 hours, they can't lie for that time. And you ask same thing again in different ways, and then you get the correct picture where that person is. So the other issue which I've noticed, which is often ignored, is pre-existing vulnerabilities and other cofactors. So a lot of people have injuries, but you often see a exaggerated response than it should be. And most of the time, the reason is other vulnerabilities which patient had or other things which happened at the time. So these things are often ignored depending on which side you're sitting due to your unintentional bias. So you may pick up and not. But I think if you can look into all those factors, then you get a better understanding and better diagnosis of the claimant. Yeah. And the last thing, which is probably the most important thing, is our PIRS rating scale. It's called Psychiatric Impairment Rating Scale. Um, it is a scale which itself has a lot of issues in impairment rating. So a lot of people fall in between the class categories, and it's very difficult to fit into one. But I think the bigger problem is the lack of training. So when you start doing medical legal work, you uh, you get trained into this, and at that time you don't know what the scale is. You just listen, and one day workshop and you learn. Um, but after you start applying it, then you realize the problems with it. But there's no retraining. You don't go back, and people sort of keep rating the way they interpret things. So there's a huge variation in the way people rate it. And I can share with you, this is something which will tell you how bigger is the problem. I did a report of a claimant, and the other side did not agree with my ratings, did not agree with my diagnosis. And so I received that report, and it said, no, my ratings are wrong, my things are wrong. And then I realized the guy who did the report on the side was one of the PIRS author. He was a trainer, and he was technically wrong. He kept saying in his report the person had pre-existing condition, but he did not give any rating for pre-existing condition. So the way you rate it, you rate current impairment and then subtract the pre-existing impairment and then get a final impairment. But he just said the person had pre-existing impairment, and based on that, he gave low rating for the current impairment. So it was technically wrong, and there's a lot of issues in assessment, like he didn't ask the questions about depression. He just said patient did not look depressed, and that's how not your diagnosis. So I'm just sharing this to tell you how big is the problem. I mean, this is someone who's very senior and should have been careful. But these things are reality. These things happen, and that's why we see so much of difference in opinion and problems. So there are also a lot of objective tools which are there in market, and we don't use them. So now there is the tools for malingering, and these tools do not take much time. They take just 10 minutes, 15 minutes. And these tools are developed based on the survey of real patients. So they have surveyed PTSD patient and collected the symptoms, and they built this tool which has certain items of symptoms which people don't have, which people who have PTSD don't have. So people who are exaggerating or people who are lying, they tick these symptoms, and this is how these tools pick up malingerers and people who are exaggerating. So these tools are, as I said, like they are not in practice, but they are available, and they are very, very useful, especially if you are doing someone who has got very inconsistent presentation, or and it doesn't take much time to do it, and it just gives you some insight and understanding. So,
right.
Yeah.
Is there a name of that tool, or?
Yeah. So there is a MENT, MENT, and there's IOP. And then the bigger tools as well, PAI and MMPI, which takes time.
So it might be worth for perhaps for case managers to consider requesting that as part of an assessment.
Yes, absolutely. Like as I said, that we are human and we do have bias, and we need to accept that. So we need to use some objective tools, which can pick up the problems. So psychologists do that very well, because psychologists they just don't rely on what people say. they do objective testing and they determine
Yes.
that way. But unfortunately, and the whole show is run by psychiatrists. There's not much input from psychologists,
Mhm.
but there are tools. And as I said, like these medical legal industry has bias and malingering and exaggeration. So people have been researching on these tools and they've come up with them.
Wow, that's really insightful.
Yeah.
I actually have one question for you from someone who's unable to attend today. And they wanted to know whether you felt there was a significant difference in the quality of an assessment, whether the person presents face-to-face or via a video link or telehealth.
Yes. So I would say 90% of assessments are fine by a video, but 10% of claimants are not suitable for video assessments.
Mm-hmm. What would make
Because,
somebody unsuitable?
yeah, so in mental health, there's no objectivity. So a lot of we rely heavily on subjective reports of people. And it's very important for us to connect emotionally and read people's body language when we are asking questions. And for patients also, it's important that they can read our body language. So the engagement is much better if they are face to face. But people who have minor problems, minor anxiety, depression, it is fine. But if somebody has big impairment, so recently, like I saw a woman who had a lot of memory impairment, and she was really impaired. She lived in Rockhampton. She had absolutely no courage to drive to Brisbane, but somehow she forgot to change her assessment from face-to-face to video because she had memory impairment. And then last moment she panicked and then she came. I was so glad that she came because I could see her anxiety and how she was panicking and how impaired she was. And so with video, sometimes you miss those subtle cues.
Right.
And some people who have psychosis or paranoia, we usually don't see them in medico-legal thing, but they should be seen face-to-face because they have. The more common problem with video thing is lack of proper equipments. So often people don't have bigger device, they don't focus, and you can see only part of their face or at the angle.
Yeah.
Yeah. The privacy is other issue is sometimes people have children in home or someone else in home. And if someone else is there, they can't speak freely because we ask about suicidal ideations and all that.
Yes.
And talk about these things in front of their children.
Right. Good point.
That could be other thing. Yeah.
Mm-hmm. All right. I have found that really insightful and very, very helpful, actually. And I know that our clients, our case managers and lawyers will find this helpful. I'm wondering if anyone who's present today has a question they would like to ask of Dr. Garg, you could unmute yourself and ask that question, or you can type it in the chat if you wish.
Actually, Dr. Great presentation. Can I just ask you one question, please?
Sure.
What happens if you get a report like you got from your senior guy that you thought was not a good report? He didn't identify certain issues. Do you write back to him, or you just how's the back and forth go when it comes to such a serious issue with psych issues?
Yes, I did write to them. So I spoke to my colleagues first and they said, oh, don't continue, just write one paragraph that you don't agree with his opinion. But I decided to write a 12-page report, technically with reference and showing him how to do a proper assessment. Yeah.
Good on you. I actually think that's important. I really do.
Yeah.
You know, sometimes people who are in these senior positions can make those kinds of errors because they forget their very own teaching. And I've seen it happen. No, good on you for doing that. Does anyone else have a question that they would like to ask? No? Well, look, thank you all so very much for giving of your time today to listen to Dr. Ashwani Garg, psychiatrist. And Dr. Garg, thank you for your time and effort today in providing that very, very insightful Meet the Specialist session. Look forward to seeing you at our next seminars and look forward to working with you more. Thank you so much, everybody.
Thank you, everyone.
Bye-bye.